Assalamu alaikum. My name is Dr. Gulrez Zahid. I will be presenting today's core urology lecture. I will continue with prostate cancer as we were discussing in past few weeks. I will be discussing briefly about hormonal therapy in prostate cancer. Basis of hormone control of the prostate. Prostate cells are physiologically dependent on androgen stimulating growth, function, and proliferation. The testes are the main source of most of androgens, 95%, while the adrenal biosynthesis providing only 5% of androgens. Testosterone secretion is segregated by the hypothalamic pituitary gonadal axis. Hypothalamic luteinizing hormone releasing hormone LHRH stimulates the anterior pituitary gland to release luteinizing hormone and follicle stimulating hormone. LH stimulates the Leydig cells of the testes to secrete testosterone. Within the prostate cell, testosterone is converted to 5-alpha dihydrotestosterone by the enzyme 5-alpha reductase. DHT is an androgenic stimulant about 10 times more powerful than testosterone. This is how it is stimulated. The seeds of androgen ablation therapy date back 1786 by Hunter. He described the seasonal variation in prostate size, the impact of castration on metastatic prostate cancer described by Huggins and Hodges in 1941. The gold standard systemic treatment for metastatic prostate cancer is androgen deprivation therapy. Androgen deprivation therapy, ADT, also referred to as hormone therapy for prostate cancer. Castration level. Historically, the castration level in prostate cancer is serum testosterone level of less than 50 nanogram per deciliter. Current methods have shown that the mean value after surgical castration is 15 nanogram per deciliter. Therefore, a more appropriate level should be defined as less than 20 nanogram per deciliter. However, the castrate level regarded by regulatory authorities in clinical trials is still less than 50 nanogram per deciliter. There are two types of castration. Surgical castration, in which we do bilateral orchectomy or subcapsular pulpectomy, while medical castration, we do it with estrogens, LHRH agonist, LHRH antagonist, anti-androgens, and androgen synthesis inhibitors. Bilateral orchidectomy. It is still considered the primary treatment modality for androgen deprivation therapy, as it is a simple, cheap, and virtually complication-free surgical procedure, easily performed under local anesthesia, and it is the quickest way to achieve a castration level, which is usually reached within less than 12 hours. However, it is irreversible. Now we will discuss briefly one by one medical therapy. Estrogens. Mechanism of action of estrogens, it downregulates the luteinizing hormone releasing hormone secretion and ultimately testosterone production. Androgen inactivation, it direct suppress Leydig cell function and direct cytotoxicity. Diethylstilbestrol, DES, is the most commonly used estrogen. However, it has fallen out of favor due to the associated risk of cardiac toxicity and adverse cardiovascular events. Hence, it is not recommended as a first-line option. While using DES, castration level reached within 2 to 4 weeks of after administration of the dosage. LHRH agonist, the preferred method of first-line androgen deprivation therapy for prostate cancer. Castration levels are reached within 2 to 4 weeks. LHRH agonist stimulate the pituitary to produce more luteinizing hormone, which causes an initial elevation in testosterone production within the testes. However, prolonged exposure eventually causes the pituitary receptors to downregulate, and testosterone is ultimately reduced and then stopped. Currently, four LHRH agonists approved by FDA for treatment of prostate cancer, namely goserelin, triptorelin, hysterelin, and leuprolide. Flare-up phenomena. After injecting the first injection of LHRH agonist, it induces a transient rise in luteinizing hormone and follicle stimulating hormone, which leading up to a testosterone surge or flare-up phenomena. It starts after 2 to 3 days and lasts for about 1 week. This may lead to detrimental clinical effects. The clinical flare with advanced disease such as increased bone pain, acute bladder outlet obstruction, obstructive renal failure, spinal cord compression, and cardiovascular death due to hypocoagulation status. Anti-androgens is kyproterone started on the same day and lasting for 4 weeks can be used to counteract this flare.
If we can stop here for a moment, let me just revise myself and draw your attention towards the relationship between a receptor and a stimulant, or any chemical which acts as a stimulant, maybe as something which is an antagonist. So, what do you think? What is a receptor? It is something like an organ, like an organelle, a structure, a button, sort of a thing. So, what is it? A very simple question. What is a receptor? Amat? So it is basically a proteinaceous structure, right? Most of the times, it might be a glycoprotein, but it is basically a proteinaceous structure. And it is something which is in transition. That means you can reconform or deconform a substance, a receptor. For instance, if there is a relationship, it is like an antagonistic relationship between a chemical and a receptor. In later time, it can become something like a stimulant rather than antagonist by a little bit of change in the structure of the receptor. So the receptor is something which is dynamic. It is not something which is static. So this is the main concept behind receptor. The second thing is, in your earlier years, perhaps in the third year of medical college, we all try to understand the concept of upregulation and downregulation of receptors. So anybody knows or still remember what that upregulation and downregulation is? Perhaps you can tell us. Ji.
Receptor, as we were discussing, that it has a protein structure which has the ligand, and any chemical substrate can come and attach to this. Any substance that attach to the receptor side, it has positive as well as negative feedback mechanism by inhibitory as well as. So in result of if it is agonist, so it has any stimulatory effect. In result is upregulation of that substance released by that after binding of that receptor, which is specifically substrate and attach, and in resulting is the result. And same as well as when it has an inhibitory effect, in result is the down regulation. Like we are talking about this prostate cancer, in this has basically physiological, this has the hypothalamic pituitary axis, in which hypothalamus first of all releases LHRH, that has the gonadotrophic analog release, which acts on the interior pituitary gland, that results in release of the luteinizing hormone, which further go towards the testes which have specific Sertoli and Leydig cell acts on the Leydig cell in resultant that secretes the testosterone, and this testosterone further goes to the prostate and bind at the receptor site, and when it's attached to that receptor, further that is converted testosterone into the dihydrotestosterone.
Right.
So this is basically a whole pathway.
Right. So again, just to summarize what we are talking about, both of you are correct, but I think your name is Nida, right? So Nida was very much clearer about the location of receptor. It might be something on the surface. It might be something in the cytosol. It might be something half of it, or maybe a portion of it is in the exterior, and the other one, a bit of it, is in the interior of the cell membrane. So there are many kinds of locations of the receptors. The second concept is, for instance, if there is a lot of testosterone, or maybe an agonist kind of a stimulant available in the vicinity of any receptor, then the receptor quantity will be a little bit changed. The quality will not be changed, meaning to say it will not be changed in its structure, but it will be changed in its number, in the number of availability of those sites where the ligands can attach themselves, right? Where the relationship can become stimulatory or antagonistic. So that is known as a down regulation. The up regulation means, for instance, the stimulant is not available, and the stimulant, since it is not available, so the receptor is in search of the stimulant. So it increases the number, the density of the receptors on a particular cell membrane. So that is known as upregulation. By conformational change, I mean to say that, for instance, if you try to figure out something like beclutamide, for instance, if you try to put your patient on beclutamide for maybe 6 months, so first of all, there is a decline in the in PSA level, because this is the effect of the drug. But later, that antagonistic relationship will turn into something which is an agonistic relationship. So an antagonist becomes an agonist in longer period of time, just because of the conformational change, and perhaps because of a little bit of upregulation of the receptor. So this is a very interesting story. We always think about something which is like a static, just like a chair or a table or anything else, but it is something which is like a ever changing sort of an environment. So this is an environment which we call receptor. It is not something which is, again, a parchment like membrane. It's not a membrane or a button or anything else. So this should be the concept that has to be at the back of our minds. And it has got its own implications, because the whole science of immune checkpoint inhibitors and things like that are coming up depend on the relationship of a chemical, which is a ligand, maybe an stimulant or an antagonistic sort of a thing, and the receptor. And that receptor might be an androgen receptor or might not be an androgen receptor. Right.
LHRH antagonist. These drugs compete for and bind to the LHRH pituitary receptors, preventing the normal signals for testosterone production reaching the testes. This causes a rapid decrease in luteinizing hormone and follicle stimulating hormone and thus testosterone production, and there is no flare up phenomena with these drugs. However, they are associated with histamine-mediated side effects, allergic reactions, which in many cases have been serious anaphylactic shock, particularly so with abiraterone and digarelix. Their benefits over the more traditional LHRH agonists are yet to be proven. Now we'll move towards anti-androgens. These have a similar structure to testosterone and bind with the testosterone receptors on the prostate cells, blocking the effect of testosterone. These oral compounds are classified according to their chemical structures in two main groups, steroidal and non-steroidal. Steroidal cyproterone acetate CPA, megestrol acetate, and methoxyprogesterone acetate, while non-steroidal or pure is naloxone, flutamide, and becloramide. Steroidal antiandrogens. Steroidal antiandrogens have progestational properties leading to central inhibition by crossing the blood-brain barrier. Progesterone properties which help to lower testosterone level, so loss of libido may be still an issue with this drug. The main pharmacological side effects are secondary to castration, while gynecomastia is quite rare, whilst the non-pharmacological side effects are cardiovascular toxicity, 4 to 40%, and hepatotoxicity. Non-steroidal antiandrogens, they don't lower testosterone levels, therefore libido and overall physical performance and bone mineral density are more likely to be preserved with this drug. However, they are not without side effects, though gynecomastia, breast pain, and hot flashes are the common side effects. Liver toxicity is also a problem with this drug. Becloramide shows a more favorable safety and tolerability profile than flutamide and nilotinib. Androgen synthesis inhibitors. It inhibits androgen synthesis in testes, adrenals, and within the tumor cells. Block testosterone production by inhibiting an enzyme called CYP17. It produces testosterone from cholesterol. Three androgen synthesis inhibitors are approved in the United States: ketoconazole, aminoglutamide, and abiraterone acetate. Now we will discuss briefly side effects of androgen deprivation therapy. Hot flashes can be significant, very bothersome, and distressful. It can disturb daily activities and plans. Methoxyprogesterone is an effective treatment with limited side effects for these hot flashes. Anemia, normocytic, normochromic, it is very common side effect of ADT. Fatigue, a common symptom and multifaceted, can be related to a reduction in testosterone, but may be also be related to other treatments, physical and psychosocial factors. Cognitive decline, forgetfulness, lack of concentration, and mood changes. Sexual dysfunction and loss of libido. Drugs that block testosterone action rather than decreases its levels may be used if a man is concerned about this, but they may not be as effective in terms of disease control. Effects caused but more likely with longer term use of this ADT. Osteoporosis, bone mineral density is reduced, increasing risk of weight gain and obesity. Lean muscle mass reduces and fat mass increases, especially around the tummy area. It increases the risk of sarcopenia, a term used to describe the erosion of skeletal muscles and general frailty, feeling weak, can increase the risk of falls and further increase the risk of fractures. Hormone therapy also increases serum cholesterol and triglyceride levels and so can increase the risk of cardiovascular complications.
So, the most important thing is this bone mineral density. So anybody can tell us, all of us, why this bone mineral density is affected with this anti-androgen therapy? Anyone? Muzair? And that is precisely the idea behind doing bone scan.
In prostate cancers, before starting with the hormonal therapy, usually the bone density scan is done to get a baseline level of the skeletal integrity of the person. Bone density gives you.
Sorry, I just
Yes, sir.
want to interfere because normally we think, and many of us will be thinking that I might be wrong in my statement that bone scan is being done just to see metastasis. But if you want to see metastasis, then the most sensitive of many imaging techniques is MRI spine, if you want to see it. But we do bone mineral density. We want to see bone mineral density through bone scan. So it's the other way around. Maybe it's written something different in our textbooks, but practically it's different.
Yes, sir. So it's to get a baseline where if you're talking about the mineral density, initially you get a baseline value of how strong the integrity of the skeletal system is when you start the androgen therapy. Now, what the hormone do is actually one of their side effects is that they create a misbalance between the calcium and phosphate exchange within the within the bone mineralization. Now, when there is an abnormality between the calcium and phosphate exchange, what happens that there is more bone resorption as compared to bone deposition. So the calcium deposition or the presence of the strong bone, in simply saying, decreases over time with the hormonal therapy. So, which is why sometimes calciums are added to these patients, so that to maintain their bone intensity. If it declined, there is a surveillance of the bone density as the patient progresses to the treatment of hormonal cancers, and a critical level of bone density, when it decreases below a level, it increases fragility of the skeletal system, and the most devastating effect is the spine, in which there can be catastrophic effect to the spinal cord, and that requires emergency treatment. And in other places, there can be pathological fractures just from simply falling down, that can lead to fractures and debilitating and poor conditions of life.
Right. So I must introduce Dr. Nida. She is the newcomer, a new resident in urology.
Sir, presence of testosterone suppresses one interleukin, that is interleukin 6. This interleukin 6 has impact on osteoclast. If this interleukin 6 is present, osteoclast activate and it increases bone resorption. Anti-androgens mean we are suppressing testosterone activity, and if we are suppressing testosterone activity, that means we are increasing interleukin 6 level. That will stimulate osteoclast, and in return it increases bone resorption. That is why this osteoporotic phenomena occur when we give anti-androgens to the patient.
Right. So that brings us to another question. Dr. Nida, you just keep your mic with you, because I want to ask you one other question, and maybe you can educate us more. The question is, whenever somebody comes to us in our clinics and the person is not knowing that the disease that the person is carrying is something like prostate cancer, and he has got one complaint only, and that is back pain, and he has got an X-ray. By seeing the skeletal X-ray, lumbosacral spine perhaps, we as urologists might judge that he has got a prostate cancer perhaps. So what is the differentiating point between an osteoporotic and a person having non-osteoporotic prostate cancer on a skeletal X-ray? Right. So you see, whenever this person comes to you with prostate cancer having something related to bone, as we are all discussing, then the bone becomes a little bit of bushy. It becomes something which is denser rather than having, as Dr. Ninda was saying, osteoclastic activity having rarefied sort of a bone. A rarefied bone is a bone which on an X-ray is just like a see-through bone. It's not a see-through bone. It is a bone which is obstructing your view. It's a bone which is having a sort of a light reflecting on you rather than passing through the structure. So it's a different kind of an X-ray, and please do see those X-rays, because they do come to us with all these complaints and all these investigations. So there is a balance, a fine balance between three things. One is the osteoclastic activity, the other one is the osteoblastic activity, and the third one is the osteoid, the matrix, the osteopontin. This is another protein which is there. So all these three or four components, they have got a different kind of a relationship again, and they try to have, in the end result, what Mazahir was saying, something which is an imbalance between calcium and phosphate. And that is precisely the reason why we prescribe them the drug which is known as bisphosphonate, just to treat not only bone pain. So bisphosphonate, if it is being given with the regular schedule, it will do away with bone pain rather than having something like painkillers. So the treatment should be guided or targeted towards something which is like the actual process being going on. Bilal, I think your research is on this thing, so please show some kind of or light on this subject. A little bit of light.
उन्होंने इतनी लंबी लंबी तकरीरें कर दी सर, बस काफी आगे बढ़
नहीं, अब पहले यहीं से कर लें, फिर आगे बढ़ जाएंगे. आगे आगे तो बहुत कुछ.
As far as my take on this is concerned, I think it's the osteoclastic activity that increases in these anti-androgen patients, anti-androgenic patients. And bisphosphonates are actually are inhibiting those osteoclasts. And if I can add to that what Dr. Asad was saying, the lesions in the prostate cancer bones are more denser, and because there is a tumor deposition in the spine, and they would appear more dense, more what is it called?
Osteoblastic.
More osteoblastic, more dense, more whiter on the X-ray as compared to those osteopenic bones. In which the calcium has been taken out and they become more less white on the X-ray. So that's how you can differentiate on the X-ray between the two kind of patients.
Regarding the side effects, I would like to add on, the majority of the side effects of the anti-androgens are due to the decreased level of testosterone. It's not directly related to drugs. If you lower the dose or withdraw the drug, the majority of the side effects, they go away.
This is table showing the drugs with its dosage. Diethylstilbestrol, its route is oral and it's given 1 to 3 mg OD. Goserelin 3.6 to 10.8 mg every 1 to 3 months. Leuprolide, it's given intramuscular and its dosage is 7.5 to 45 mg every 1 to 6 months. Hysterelin 50 mg annually. Triptorelin 11.25 to 22.5 every 3 to 6 months, while Lijarelix is 80 mg every month. Ketoconazole is given 400 mg on daily basis. Aminoglutathamide 250 mg 4 times a day, while Ibritron 1000 mg daily. Glutamide is given 50 mg daily. Glutamide 250 mg TDS. Nilutamide 150 mg daily, enzalutamide 160 mg daily, apalutamide 240 mg daily, darolutamide given 600 mg BD.
Regarding these multiple anti-androgen deprivation therapy, none of them is proven to be superior to other. Almost all are. It depends upon the compliance of the patient on the dose of administration. Like it's better to have a 3 monthly injection than a daily tablet if a patient is okay with it. So, what is your take, Dr. Sadonat?
Again, that depends upon your society and the culture in which you are practicing. If you think that your patients are pretty compliant, they can follow your advice, they can follow your schedule, follow-up schedule, then it's good to have on a very shorter term regimens. But a longer term regimen has got something to be thought of, because in the West, again, these drugs with greater half lives and greater periods of dispensation, they are always something which are out of control in terms of side effects. For instance, if there is any side effect of any drug, you can't just withdraw them because they have got a very long sort of presence in the body. So if you think that your patient is again, as a clinician, you have got all the rights to do and decide. But again, for me, I think I want to keep my patient and my judgment in control of myself rather than giving it to somebody else.
When we are talking about the side effects by hormonal therapy, the role of intermittent androgen therapy is how much helpful in this regard? Yes, we are stopping.
Right. So in the late 90s, because my presence in urology was started in 90s. So there was a person called Fernand Lebri, and he happened to be a Swedish urologist and as well as endocrinologist and perhaps oncologist also. So he happened to visit us in a few of our symposia in SIUT. He propagated this concept of complete androgen blockade at that time in 1995-94. And he thought of that if you do subcapsulolectomy plus prescription of anti-androgen therapy, then that would do away with the disease completely. But what happened was, maybe in 1997 or 98, a paper came up in the international literature by the same person, Fernand Lebri, and he said that I was wrong. I was totally wrong because everything was coming up to him, because all these patients were turning again because of the same concept of putting the anti-androgen into the stimulant sort of an area, maybe 6 months down the line, maybe 1 year down the line. So and then at that time, there was nothing available in terms of second line therapy. There were no baclutamide. There was no other drug in that class. So those patients were actually moved on to chemotherapy. And at that time, the chemotherapy was again something like ketoconazole and things like that. So that was a very devastating sort of era. And very smartly, whole of oncology as well as urology turned against the same idea, and we thought of just putting one weapon in front of the patient and just hiding the other one. Meaning to say, if you want to treat your patient, do subcapsulolectomy and do not prescribe anti-androgen at the same time. Keep it for maybe 1 year after, maybe for 2 years after, till such time that there is a rise in PSA, till such time that there is an escape phenomena. So that was a concept, and it is still being practiced. So that is an sort of the same concept that you are actually alluding to.
Last, we will revise briefly what we have discussed already. GnRH agonist, liprolide, goserelin, triptorelin. It stimulates release of luteinizing hormone. Feedback loop ultimately decreases LH production. Its mainstay of therapy for metastatic disease leads to increase in FSH, considerable side effects. GnRH antagonists, dagarelix, abrelix, and ketorelix. Its site of action is pituitary gland. It binds to receptors and blocks release of GnRH. It prevents testosterone surge, leads to decrease in FS. It also have considerable side effects.
So thank you very much for today.